Okay, everybody, it's 12:01. We're going to get going with today's webinar. Real quick housekeeping item is you will be getting this deck that we're presenting today, as well as the recording for your purposes right after this session. Just want to welcome everybody. Today's topic, as you can see here, is how can payment and revenue integrity align and create value in healthcare. I want to start off before we jump into the topic, introducing who you'll be working with today. So my name is Dana Finnegan. I'm the Director of Market Strategy at MD Audit. I'll be acting as the facilitator of today's session. But a little bit about your two main hosts. Our first is Ritesh Ramesh. Ritesh is the CEO of MD Audit. He has spent well over 20 years across many industries, particularly healthcare, doing some very important business transformations using data, analytics, and emerging technologies. He's worked with all stakeholders across the healthcare continuum, including payers, providers, and life sciences companies. Deeply understands the pain points that many of you are facing and how to help you gain the insights you need for positive outcomes. Really happy to have Ritesh here today, a really great subject matter expert. We're also joined by Dave Cardell. Dave is the Chief Strategy Officer of Advanced Medical Strategies. Really happy to have Dave here. He's a registered pharmacist with well over 30 years of experience in the healthcare industry. He's leveraged years of expertise and subject matter expertise in payment integrity industry. He's worked with health plans, he's worked with providers and many other folks to help them improve payment integrity outcomes. Both of them are here to give us insights and strategies on really how to deal with revenue integrity and payment integrity. I think before we dive in, I want to give a quick narrative about why we're here today. So really, we hear a lot about providers and payers in this space, how there's coexistence and how they're aligning to provide value in healthcare. But we also hear a lot of friction between the two as well. So a lot of stories about alignment, a lot of stories about friction. I think we want to talk today about how the two can coexist comfortably. One thing I want to bring up though, and you'll be getting this as well with the deck, is I just read a fabulous, really interesting article that was just put out the other day by MedCity News that was talking about how commercial payers, in contrast to the government payers, rising claim denials kind of going through the roof. Not only are they denying more than they ever have, but there's a lot of studies out there talking about how it's taking them even longer to pay claims. So well over 90 days to adjudicate and pay claims compared to their governmental counterparts. Along with a massive amount of denials, one of the other pieces that was very interesting is a very strong segment of those denials were specific to what they call RFIs, or requests for information. Those really tricky denials you get for information needed, informational documentation needed, even those medical necessity ones. And this study found that commercial payers were 12 times higher to deny for those categories than their governmental counterparts. So again, we're hearing about alignment, but this is creating some friction and abrasion with providers. Finally, I think what's happening here is, although they actually finish and pay these claims well after 90 days, that's putting an enormous burden on providers because they have to throw a lot of administrative effort at it, and it's really affecting cash flows, regular cash flows. And we know that this is a really difficult time for providers and facilities. So that's why we're here today. So both Ritesh and Dave can shed more light on that and actually provide some really good insights on how we can all work well together. So what I want to do right now is just start off with really our first presentation and slide. And the first thing we're going to do is turn it over to Ritesh. We're going to ask Ritesh to talk to us a little bit about revenue integrity, specifically what it entails and how it can be achieved.
Great, thanks, Dana. Before I get started, I want to thank the audience. I see around 80 plus participants. I know that we are coming off the long weekend. So I want to first thank you for taking the time and be with us for the webinar. So in terms of the revenue integrity question, there are a lot of definitions, but I think the best one I like is revenue integrity could be a program or a function within an organization. But if that program has a North Star, I would put three things, which I would call it as revenue integrity when it comes to end outcomes. Number one is our provider organizations trying to maximize reimbursements. And that is to plainly say that how are you going to get paid for the services you perform in a timely way? Getting paid subsequently, as Dana said, is not enough. Getting paid quickly is what is needed in today's environment. So that's the first question. The second one is mostly around how are you going to do it in a very compliant way? Maximizing reimbursements doesn't mean that people can overcode and get there. So compliance is a key piece of the equation. And then last but not least, how are you going to do it in a very efficient and cost-effective way? And we're going to talk about technology in other parts. But those three ingredients is what defines a revenue integrity program or a function in terms of maximizing reimbursement, making sure that you're doing it in a compliant way. And then the third piece is you're going to do it in a very efficient and cost-effective way. One of the things that we have done in the last 12 to 18 months, going through our customer base and really studying customers who do it in different shapes and forms and figuring out what is the magic formula to execute a program like this and be very successful. We have found 4 common characteristics, and I'm going to break it down very simply in terms of the people, process, technology. It starts with people, and every single program, whether it's finance-led, or revenue integrity led or some other function led, needs to be cross-functional in nature. It cannot be siloed. And any programs which are siloed in nature, it's not going to go anywhere. It might have a name, it might have people underneath it, but what you'll see is it really does not go and get the ROI that you need. So the first thing is, if you're setting up a revenue integrity program, make sure that from a people perspective, it is cross-functional in nature, that you have equal representation from different teams, be it billing, compliance, coding, IT, revenue cycle, and I would even argue patient experience, and making sure that you have a structure to this and executive buy-in from these functions, because it just needs to be cross-functional in nature. In terms of the process, I think many of our customers who have had great success with revenue integrity programs, many of you who are on the call, they have a formal structure. A simple example is they have a monthly steering committee. They have a program, and the program has a bunch of operational KPIs and metrics. So this allows them to execute, but also come back to the center and talk about some of the wins, quick wins, some of the metrics, some of the key areas of focus for the program. So I think setting up the process is so important to make sure that not only you have a cross-functional team set up, but also you have some kind of formal structure where folks come together at different levels, just not operational, but also executive level, to really kind of fund the program, communicate the key wins, communicate the kind of priority areas so that teams can execute and get some quick wins. And last is the technology piece. You really need the technology and analytics to make sure that it supports the people and process. I've been a chief technology officer in the past. I've been a technologist for the last 25 years, and I'll be the first person to say any place which tries to force technology without taking into account the people and process components, it's not going to go anywhere. So I was going to break it down into those 3 areas: people, process, technology, where you want people 40% of that on the people side, 40% of it on the process side, and then set up the technology to help the people and process so that your program could be more successful. So that's my perspective on how do we define revenue integrity in terms of the North Star, and how can you really kind of execute and get stuff right.
Great, great. Thank you very much, Ritesh. Now I'm going to turn it over to Dave. And Dave, if you could talk to us about payer integrity, as much as Ritesh did with what it is, and what are some of the end goals and how payers are practicing it today?
Dave, I think you're on mute. We can hear you.
Sorry about that, folks. Thanks, Dana. Thanks, Ritesh. I'm really excited to be here today. This is a topic that's really kind of close to my heart, having been in the payment integrity space for over 30 years. I think we're at an inflection point in the industry with, as Ritesh mentioned, with advancement in technology, the content and the data that's now available that could not even be curated, let alone, processed. Technology has allowed for an AI, just exponential growth in these type of programs, whether it's revenue integrity or payment integrity. And I think that's part of the drivers to Dana's first point. We're seeing a lot more activity on the payment integrity side. And I think technology enablement has really, and AI has really contributed to that increase in what you're seeing probably on the provider side. The payers are definitely taking a closer look at this. I thought it'd be useful to at least give you the mountaintop view of the end-to-end continuum of what payment integrity programs are, and a pretty comprehensive view from the payer's perspective. And these are programs that they have in place. It's not limited to this, but these are the top programs and subcategories within that. But I think first of all, it's important just to see the different points of integration of delivering payment integrity solutions from the provider's perspective. And they do it either internally with insourcing with their own nursing staff, pharmacists, coders. The large payers will also layer in vendors to do a lot of this work, especially on the post-pay side, some on the prepay side. So there's sometimes stacking of vendors, and some payers have 15, 20 vendors doing different things. Not all payment integrity vendors are expert in all of these things. So some specialize in one or two or more. So there's a quilt kind of patchwork of vendors that are stacked. But, starting with the very beginning on the right-hand side of the continuum is where it all started, many years ago when I started with hospital bill audit. Traditional hospital bill audit was really the main payment integrity. They called it cost containment at the time. But as you can see, it's grown exponentially since then. And the reason is that there's been a lot of consultants over the years working for self-insured and ASO customers of these payers. And these consultants have identified overpayments and areas of opportunity for cost savings. So really, it has become more and more over the years a fiduciary responsibility that drives a lot of the activity that the payers do in the payment integrity space. And they really have been ratcheting that up. It was a nice to have 30 years ago to recover money that had been paid out the door to them in overpayments, and now it's kind of table stakes, and it's something that just is part of their budget. I can tell you that at an executive level, the payers, the big health plans, they really don't want to do payment integrity auditing, right? This is a huge cost for them. It's an army of people of all different kinds of high skill sets and subject matter experts to do this work, and it's something they really don't want to do. And I know that sounds a little surprising to some on the provider side because it's so pervasive, but it's kind of a necessity for them from a fiduciary responsibility. Another point that I want to make is that the overpayments that they're going after, they really do view this as overpayments to contractual terms and just bringing, payment to what is supposed to be accurately the first time is their goal. They want to improve that payment accuracy. They want to eliminate the administrative cost and rework. That's something they work very hard at. And they really, really take seriously provider abrasion. They want to reduce that. And again, that sounds a little surprising because as you see the dramatic increase in the number of audits and, medical record requests or documentation requests, you could say, well, if they really want to reduce provider abrasion, how can that be going up? And I think that, part of it is technology has enabled them to do more quicker, better, faster, to zero in and find claims that they believe are overpaid. And a lot of that is, again, trying to scale to meet their budget internally for their payment integrity goals. And again, reduce those overpayments is their goal. So ultimately, I think there's this very mutual goal of payment accuracy that can reduce a lot of administrative work, cost, time and speed up payments if both sides were able to collaborate. And I feel like the industry for the first time is at this inflection point where both sides really do seem to want to get together and share information, share business insights, instead of surprising a provider and hitting them over the head with, you know, all these audits and medical record requests. By sharing the screening logic of some of these categories of overpayments and programs that they have, and allow the provider to kind of have that advanced information to verify things on their side before they push the button and that claim gets submitted, I think is super important. So very quickly, the pre-bill or at the provider, which you're very familiar with, is the first point of integration of payment integrity or payment accuracy solutions. The payers also are starting to leverage pre-submission or the clearinghouse to serve a role and using technology to identify these claims within nanoseconds, you know, before that claim ever gets to the payer's front door. If there's things that can be resolved there, there's more and more programs that are shifting as far to the left as possible, and pre-submission is really gaining a lot of attention from the payers to deploy payment integrity logic and content there to catch those claims before they even see them, and have the clearinghouse do that using 277CA status code messaging. The one that's really become a large area of payment integrity intervention is at prepayment. There's been a push over the last 10 years for all the traditional post-payment programs to shift, if possible, if it's reasonable, if it makes sense, over to prepayment. And I think that's also part of what's kind of causing further delays in your payment and your cash flow. Because as you move these things forward, you know, if they're asking for records before they make that payment, they're depending on the provider submitting those in a very quick turnaround time with itemized bills is one of the biggest. One program, just as an example, that's really become huge over the last few years with technology is itemized bill review, and looking specifically for not separately reimbursable or unbundled policy. And in fact, the Blues Association several years ago mandated that there's a prepayment review for these types of things on an itemized bill on claims that are $100,000 or more. And some payers, commercial payers, have actually seen so much savings in overpayments from things being billed through that they've reduced that threshold down to $50,000 or different lower thresholds. And that increases a tremendous amount of itemized bill review type of activity in the prepayment stage of the end-to-end processing. So I'm not going to read all these different programs. I'm sure you're familiar with them all, but I wanted to share that with you. And you're going to, I think, as Dana mentioned, you're going to get that in the package as well. So that's my thumbnail sketch at a high level of the payment integrity end-to-end continuum, you know, from a payer's perspective.
All right. Thank you very much, Dave. Yeah. And as Dave said, we'll be sending this out with the recording. You won't miss any of it. So I'm going to move on to the next slide. We got a little interesting one here. I want to hear more about this myself. Is what do payer integrity and revenue integrity have in common? And more importantly, how do they intersect? So Ritesh, I believe you were going to start off with that.
Yeah, I'm just going to probably anchor on what Dave said. I know that we've read a lot about the friction and the aberration. I think when we zeroed in and focused on, let's kind of look at the positive side of things and look at the common goals that both of them share. So these are the 4 dimensions which we thought about. So if you really look at from a patient perspective, most of the providers really wanted to provide excellent care and patient experience and access at the end of the day, and them being financially and operationally efficient makes them do that really well. We talked about payment. Providers want to get paid for the services they provide. Neither undercoding is good nor overcoding is good. How do we really land in that sweet spot where you could code accurately, capture documentation, and get paid faster? And then when you really look at compliance and efficiency, it's again, like a lot of provider organizations are focusing more and more on compliance programs, because gone are the days where compliance was, hey, this is something which we have to do, versus now it's a real financial risk for many of the CFOs. Because I often tell people that even overcoding has a lot of implications on folks reporting revenue and going back and restating revenue a couple of years after or whatnot. So if you really look at patient payment compliance and efficiency perspective, and what providers want to do, they want to do right with the patients and also make sure that they get that operational processes right, and contain cost. And I think that is pretty much, when you look at some of the things that Dave said on the payer side, we kind of see that it's almost like it's two sides of the same coin, in the sense that payers want to do the same thing when it comes to payment accuracy, making sure that patients have excellent plan benefits. They want to be compliant and they want to drive down costs. So it's a great opportunity for both sides to come together and focus on some shared goals, and then use that to establish trust and transparency to drive this relationship forward. And at the end, the patients are the ones who are at the center of this, and they'd be the winner in terms of what they're going to get.
Great. Thank you very much, Ritesh. And before we move on, I do want to have Dave talk to us a little bit about what are some of the biggest challenges that payers are facing this year?
Great question, Dana. Payers are really struggling with provider abrasion, as I mentioned earlier. And again, kind of behind the curtain, they talk about this all the time. And for 30 years, I've worked with the top 100 plus, payers, from the largest to the smallest to the MCOs. And there's not one that doesn't bring up as one of their highest priorities for a payment integrity vendor, an audit vendor that does this type of work for them. It's right at the top of the list as far as provider abrasion. They want to make sure that the information that's being requested, the medical records, the itemized bills, invoices, whatever is being requested to do the validation and audit work, that it's got a very high success rate, and success in their eyes is, making sure that there's an overpayment that's valid, that can be recovered. So they have been really focused on trying to reduce the number of requests that that come up empty from their perspective, and just ask for the records that actually do have those overpayments on them. So they're constantly trying to improve that, and they're putting pressure on their vendors to do that. The other thing that they're challenged with is the high cost associated with the work that they do. A lot of this is manual, and it requires highly skilled nurses, pharmacists, coders, and sometimes even physicians on medical necessity reviews. So it's a very high manual cost for resources on their end. And as I mentioned earlier, literally armies of auditors doing this work. And so that's very difficult to manage that type of personnel. So what they're really shifting towards is more automation, using AI, leveraging AI tools to be more efficient as well. And I think that, they struggle because, as I mentioned, the executive level of the health plans, they really don't want to do this work. They don't want to fund this and resource it. And it's a big part of their budget. But they also have that department that has goals that are always increasing year over year to find more money. So they're always trying to innovate. What's the newest thing that's happening in the industry where we can save more money to hit our goals at that mid-level management within the payment integrity division? They're always trying to save more money. So when I think about this and what we're talking about today, it's like the perfect opportunity to start to think outside the box. And instead of doing the same thing over and over again and just increasing the velocity of that, it just seems like it's the right time to start to share data insights, business intelligence, screening logic. If a payment integrity vendor or a payer has logic, which they do, and algorithms that are going to immediately and in an automated fashion pick off claims that are going to be either denied or chosen for audit or requesting additional records, why not advance that information over to the provider before they do the audit, save on the audit administrative costs and all the rework that's involved, and the overpayment recovery and financial reconciliation? By sharing that, it's very beneficial to the payer, and I believe just as valuable to the provider to have that information before all these audits and denials are kicked off. And that's at the crux of, I think, where is a huge opportunity. Now, there's always going to be errors and we're not going to get it right, 100%. But even if you can start to, through that strategy and collaboration, start to reduce the amount of audits by 10, 20, 50%, that is a tremendous benefit to both provider and payer. So that's kind of what they struggle with, Dana. And that's kind of in my mind's eye where I've been for many years, kind of waiting for the environment to be where both sides can start to collaborate to get the mutual benefits.
Thanks very much, Dave. It's great to hear that we're getting closer and maybe some of those synergies will happen, lighten everybody's load and worry. Now I want to flip the slide here and turn it over to Ritesh. We just heard about some of the biggest challenges payers were having. Ritesh, can you talk to some of the challenges providers are facing?
Yeah, so in terms of the macro level themes on the provider side, we have read about this all, and folks on the call are mostly on the provider side. The first thing is profitability. And I think that's been the topic in this industry for the last 6 to 12 months, even after the pandemic, as the volumes have started increasing. There's always this cost component and inflation eating into profits. So profitability is one key concern. And then the second concern I hear all the time from the operational leaders is prioritization. What should I prioritize? There are so many issues. What are some of the high impact areas that I can prioritize and help mitigate to drive ROI? Because you have so many facilities, so many providers, and so many areas of high impact. And then the last one is staff shortages and management. And that's where we think that technology can really help. Is there are so many things to do. How can I do more with less? So if you have to summarize those macro level themes, profitability, prioritization, and then staff management. And on prioritization, one of the things I want to talk about is this, what you're seeing in front of the slide, is if you look at it, we spend as an economy around $5 trillion in healthcare, out of which more than $1 trillion, out of 5 trillion, more than $1 trillion goes into these three categories. One is drugs, around 600 billion. The other one is durable medical equipment, implants, some of the medical devices, which are around 150 billion. And then the last one is around complex diagnosis, which is around 485 billion. So if you really look at these three areas, this is what I would describe as $1 trillion problem within healthcare that we have. And all the health systems actually intersect in this problem because they have a lot of denials coming from the payers into these areas because everybody's trying to figure out how to be efficient in payment accuracy and revenue integrity. So I think this is one thing that most of the systems are currently looking at. I would kind of describe this as 3, 3, and 3 revenue area code categories for you in terms of drugs, implants, and complex diagnosis. 3 place of service areas. Normally, this is outpatient. It's happening in the ambulatory service centers. And as more people are trying to push inpatient to outpatient place of setting, I think you're going to see more and more services performed on the outpatient side. And then the last is the request for information issue that Dana was talking about, where commercial payers are requesting more information and pushing back and paying very slowly. It's not a coincidence, we are seeing that happening a lot in these 3 areas. It's happening in drugs, it's happening in implants, it's happening in complex diagnosis. And we within MD Audit are really focusing on these 3 key areas because we really think that's where the biggest bang for the buck is in terms of making an impact. And we have been working very diligently on some of the solutions which goes at the heart of this problem in kind of enabling health systems to catch things before they're being paid, to kind of say that what can I do to remediate these claims, because normally these are high dollar claims. These are claims which drive your profitability. These are services that might be elective surgeries, and these are all important. So those are all some of the challenges I would describe within healthcare, both at the macro level and then the micro level, going a level down, which is around drugs, implants, and this. Before I forget, one other thing to this, which is important, is everybody would have heard about the 340B drug pricing program. That program traditionally has been a big driver of financial success for most of the healthcare providers, and that program is mired in a lot of litigation over the last 1 year. And as we are waiting for decisions on the 350B program from different courts in the country, it has implications not just on the 340B covered entities, but also on the non-covered entities. Because one of the things that the Medicare did in the last 3 years is when they decreased payments for the covered entities to make the budget neutral, they increased payments for the non-covered entities. And now we are talking about coming back and kind of almost unscrambling the egg, as the appeals court called it. So I see a lot of more action in this area, especially on drugs and medical devices, and that's what I will leave some of the audience with is, as you think through your revenue integrity program and the focus areas where you can make the biggest impact, think through these 3 areas and what type of impact does your L system have in terms of denials and revenue implications.
Great. Thank you very much, Ritesh. So now that we've heard about some of the struggles on the payer side, some of the struggles on the provider side, what I want to move to this slide here. But what I want to do now, Dave and Ritesh, is really just finish up with a couple of things. And I'm going to have Dave go first. We're hearing about the friction. Things could get better. But really, Dave, first to you, what can be done to overcome this? Overcome the friction? I know you've talked about it, but just to kind of summarize that, what can be overdone to overcome that friction on the payer side? And then Ritesh, I'm going to ask you to jump in to talk about that on the provider side.
Great. Yeah, thanks, Dana. Let me dig a little deeper and be a little more specific around, I think documentation requests are one of the biggest burdens and drivers of provider abrasion. And so when I think about, what's happening with this exponential increase in the number of records being requested, and a lot of they are becoming more accurate, where they are selecting claims that actually do have a higher rate of overpayment in their selection. So you're seeing this exponential increase. When I think about this, there's probably one pet peeve that I have from the industry in being kind of confrontational between provider and payer. There's 2 separate kind of claim sets, the underpayments and the overpayments. And those 2, even though both sides, provider and payer, are doing similar things, it's on different claims most of the time. The payers aren't really looking at the underpayments, or at least the payment integrity. Teams are not looking at that. They don't have algorithms. They're not trying to find underpayments on your behalf. So they're really just dealing and focused on the overpayments. And so it's the same kind of function on both sides, but it's usually on different claims. The things that are common are the denials. When it becomes a denial and not an audit, and they're trying to deny something on a prepayment, that's where it does affect both sides equally. One of the things around the records, though, that I wanted to dig into a little bit is, if you think about it, every single health system and facility with technology now and EHRs have itemized bills digitized. 100% of the claims are likely to be digitized, that information. And the payers are, if you can believe that they're trying to get to accuracy and not take money that you deserve, and it's really just bringing it back to the contracts and the policies, then there is a way to kind of work together that way as well. Providing an itemized bill in a more efficient manner can really take a lot of steps out of the process and expedite payment, accurate payment for the provider. I know it sounds, over the years, it's been somewhat of an obstructive kind of a process where you want to try to limit the amount of, itemized bills and medical records that are being sent. And that's fine, but that just increases the level of abrasion both ways, and it does delay things. So providing a little bit more efficient way for the payers to do their work, and you still have the ability to contest something if they don't do it accurately, I think could really facilitate and reduce the abrasion and increase the rate of payment, by allowing the payers to do their work. And then, as I mentioned earlier, just kind of collaborating with them so they can share their data insights with you in a way that helps you fix things first before it gets to them, I think can also dramatically reduce the abrasion and the amount of cost on both sides.
Great, great. And Ritesh, can you just talk a little bit about what, providers can do to make this a little bit easier of a relationship?
Yeah, I mean, to me, the core thing is establishing trust and transparency is the first step. And what better way to do it than data and facts? To me, that is the key thing. Like, do you have systems in place where you can share information, like Dave said, where both sides can align on a foundational set of facts and data points, which not only helps you fix some of the systematic issues on both sides, but also help you in some long-term negotiations of your payer contracts and things like that. So this is where I think technology can play a big role. Again, as I said, I don't believe technology can be autonomous. You hear a lot of marketing in healthcare around autonomous systems, etc. There needs to be always humans in the loop. But that technology can really provide the boost in productivity is helping you find the needle in the haystack when it comes to risks, be it compliance risks or revenue risks, and then gives you the ability to share that foundational fact, trends, some of the issues which you see on both sides so that the relationship is more mutual and collaborative, and then it can just build trust versus some preconceived notions and stuff like that. So to me, data and facts are kind of key. And that's what I really think technology can provide a big boost with analytics, AI, and some of the interesting things which are ahead of us.
Great, Ritesh. I think that takeaway is, data can create data sharing between the two can create collaboration, transparency, which equates to trust. So what I want to do right now, before we jump into a quick demonstration, is just send it back to both Dave and Ritesh, because we want to send people away with just some final takeaways. I know we've talked about a lot, but if you two, Dave, why don't you go first and then Ritesh follow? Just quick summary of a couple of key takeaways for our audience today, whether they're from the provider side or the payer side.
Great. Thanks, Dana. Yeah, the payers it's hard to understand just how serious they take provider abrasion. And I think that's something that providers can actually take advantage of, but through collaboration. I think those are great discussions to have that don't happen today, that could happen between both parties. Talking about the way that information can be transacted back and forth, some of that additional information that's needed, and getting to understand why they need it. And I think that payers would welcome those conversations. I just was talking with one of the large blues recently, probably last week, about this same topic. So it's front of mind for them. They want to collaborate. They want to work on trying to reduce the amount of abrasion, noise, cost, rework. And I think, the biggest takeaway is I think we're at the point in the industry where that level of mutual trust and collaboration is there for the having if folks are willing to take that step.
Great. And Ritesh, you want to close with just some final takeaways for our provider side?
Yeah, in terms of takeaways for people in the audience who are thinking about the revenue integrity program, these are some of the things that you can kind of think through, the way you're going to set up the program, the metrics you're going to care about, what are some of the focus areas for the program, and are you investing in the right people, process, and technology dimensions to drive value for your organization? And for folks in the audience who already have a revenue integrity program, I think the biggest takeaway is, are you really focusing on the high impact area where you can kind of focus on basically 20% of the things in your system, which drives 80% of the risk? And what are you really thinking about it? I think the three areas which we presented was a good foundation, because we truly believe from the data we have seen within the MD audit community, that is a big systematic issue where there can be quick wins. But what are some quick wins and focus areas that you want to really go back to think about? So those are the two key takeaways for the two segments that are frame as. For folks with no revenue integrity programs, how are you going to really set that up and drive value? And for folks with revenue integrity programs, can you put a focus on some of these high impact areas which we discussed?
Great. And before we jump into a quick demonstration, I know, Ritesh, you wanted to talk about what we're seeing on this slide. I know we're all passionate about it. So if you want to speak a little bit about this, We'd appreciate it.
And I think this is something that Dave has championed last year. There is a Congress, a webinar at a conference, 2-day conference in Boston this September, where stakeholders from payers, providers, and some of the vendors are coming together to address this whole alignment between payment and revenue integrity Congress. And again, the goal of this conference is to have people talk, establish trust, encourage information sharing, ideas, etc. So if you're really interested to attend this conference, there is a website which is being set up, and that is something that you can register and attend. We are also looking for a panelist from MD Audit's perspective. So if you're really interested in attending this conference and sharing your perspective in terms of insights in the space, we would welcome it. And I would highly encourage you to speak to your CSM, and we'll welcome the opportunity to have you as a panelist. So that's one thing that I wanted to kind of provide an update to this audience to leverage and be part of the conversation post this webinar. And again, as I said, the website link is in the deck, and you're going to get this when we send the materials out.
Great. So I'm going to actually do a quick demonstration, folks. I think you're going to want to stay tuned for this. Just give me a second. I'm going to sign into my environment. We're going to actually present to you what's called the MD Audit Revenue Integrity Suite. So if you just give me 1 second, I'm going to sign into it right now. And what we're going to do here is really, I can encapsulate everything that we've talked about. Really, at the end of the day, it's not sufficient anymore to eventually get paid. You cannot wait 90 days to receive that cash. It can be catastrophic to bottom lines. So I think one of the things that we talked about today, Dave and Ritesh, was investing in technology, to get paid faster, even, help with education across your organizations on what can be fixed and when, and how to fix operational issues that may be deficient. So we're going to do a high level today of the MD Audit Revenue Integrity Suite. And I want to start here with what's called our Revenue Optimizer. And I'm going to start here. What I think you're going to be able to see here is what we're able to do is help you identify root cause of your systemic denial issues. So let me just get that set up. So what you're seeing here is exactly what Ritesh and Dave talked about. Is you're seeing that denials for pharmacy here. You're seeing denials for DME and implants. And then what's encompassing all of those is those high risk diagnosis codes. Again, that 20% of your volume that's causing 80% of your denial volume and pain. So what we're offering here is a system that can ingest your remittance advices on a daily basis and provide you these very insightful data visualizations that help you drill down to root cause. And then once you understand your historical denial patterns, you're able to become more predictive. We're going to show you that predictive piece in a minute. But what I'm doing here is I'm going to my revenue code 270 for medical, surgical supplies, and DME. And I know I've got a huge denial issue here. But what I need to do is actually drill down and find out what are the HCPCS codes by name. Or codes that is driving this huge denial piece. And you can see I have a ton here. What I'm going to do is very easily and intuitively stack rank those. And I see a lot of things like joint devices and screws. I'm going to concentrate on this stent. We see a ton of denials for placements of stents. So now I know that I've got this massive issue with stents, huge denials. But what I want to know next is I need to be able to, across my organization, understand where this originates. So I'm going to first type in facility name. This is going to help me understand for those stents that are denying so much that I need to start with this facility. So many of you in the big academics and even not the big academics are saying, I need to scope this down to where to start. So now I know I have an issue with my revenue code 270. It's a ton of stent denials. I know exactly what facility to go to first. And now what I'm going to do is say, okay, but what are the reasons? What are the actual reasons why this is denying? Just off the charts, why is it denying? And I'm drilling down again to that root cause immediately. And of course, I'm getting that denial that flusters me. Claim service lacks information or has submission and billing errors. That tells me a little bit That's the claim adjustment reason code. But now I'm able to drill down to the actual remark name, which is going to give, that's the RARC that accompanies the card. So I'm going to let that load. That's going to give me a little bit more information about why this is happening. And it's telling me, you know what, those are not the appropriate procedure codes. And then finally, if I want to take a step down a little bit more granular, I can even say, is it one payer? Is it 10 payers? Who is scrutinizing me for this? And it's going to drill down and tell me that it's this payer. So what we want you to take away from this first part is we have the ability to ingest your remittance devices on a daily basis and allow you to drill down to root cause immediately. So you can learn from your systemic denial hotspots by facility, by CPT, by whatever it may be, so you can have the insights to become more predictive going forward. So what do I mean by predictive? What I mean by that is you learn from your historic insights, but then you can use our predictive engine. And what the predictive engine can do is really help you increase your first pass pay rates for those, what we call non-adjudicated claims. What does that mean? Non-adjudicated claims means your pre-bill charges as well as prepayment, meaning just because the claim's gone out the door, you still have the opportunity to fix it before adjudication. Like we said, payers are taking a longer time. So what you're seeing here is how I can configure our predictive engine. And why is that important? We don't want you holding up all of your pre-bill charges. You need that cash flow coming in. So what I'm able to do is now say, look, on that diagnostic exercise I did on my historic denials, here are my facilities that are affected the most. And then I can also go in and say, you know what, I'm getting a huge issue with my 0270 DME implant revenue codes, or you can add several there. You may even want to get down to, we saw that payer that was bothering us. We'll put in a few payers that we want to concentrate on. We can even get down to CPT codes. So what you're seeing here is the ability to go in and say, based on what I've learned from that historic data, I want your revenue integrity suite to interrogate these very specific non-adjudicated claims and tell me what is going to deny, why it's going to deny, and how to fix it before it even either goes out the door or before the payer adjudicates it. And again, this engine is going to very much concentrate on that 20% of your volume that causes the highest dollar denial impact. Now, what do I mean by that? A lot of traditional claim scrubbers, they do a great job with data validation and things like that, but they're not catching what you're seeing here. And I'm going to show you some examples of that. Let's go into orphan drug use. Let's start there. So what you're seeing here is the revenue integrity suite has interrogated those non-adjudicated claims and pointed out several accounts. You can see pages of accounts with very, very high dollar volume here. We're not going to make your staffs worry about the $100, $200 claims. We're going to point out those $19,000, $20,000, $30,000 claims. And what it's saying here is, look, you're submitting this J code with this revenue code, but we are going to deny you because that drug's not approved by the FDA for a specific diagnosis. Now, I can even bring in, if I want, what is the diagnosis that they're having an issue with? And I can see the diagnosis code right here. It's also very easy for me to come in and say, what is the payer's name that's denying this? What you're seeing here, folks, is the ability for us to act as another layer on top of your scrubbers and find things that will deny, and even give you suggestions on how to fix them. Now, this one here may not be as easy as just sending the record or slapping additional documentation, but what it's going to do is give you the insights to then make changes within your organization. Educate providers, educate administrators of this issue that is rampant. Another one I want to show is orphan drug usage. This is another really big one. Again, something traditional scrubbers can't catch. And you're seeing just hundreds of account numbers here. And you can see just massive amount of denial dollars that this is happening. And what they're saying here is, you're using these orphan drugs, but we are not in alignment with the diagnosis that you're submitting. It's a great opportunity to maybe build some claim edits in your host system, stop these before they go out the door, work with your payer, understand what the documentation they need is so this can get paid. And again, educate providers, educate others in your organization on how to fix this so you recognize higher first pass pay rates. One of them that I'm going to end with here is one that is really rampant within the MD audit community. And that is, as you see here, biosimilars. Let me explain that. Or you probably know about this, you're probably feeling the pain. But what we're able to do here again is find you your very specific account numbers for those non-adjudicated claims, very high dollars here, 19, 20,000. What our predictive engine is able to say is, hey, you're submitting this J code, you're treating your patient with Neulasta, but we're going to most likely deny this because biosimilars are available. So again, may not just be a simple tweak to a claim, but this is providing unbelievable insights so you can go back and fix operational issues, educate your providers, do the things that need to be done so these will get paid that first time around. So that was a little bit about drugs. I do want to talk quickly about implants because I did that analysis on the stents. We actually have a couple of clients that are using our revenue integrity suite and recognizes some huge return on investment. And I want to give you two very specific use cases because I think everybody in the audience is going to find these familiar. So one of our customers leveraging our RI suite was specifically submitting claims for DME devices for cardiology, where there was a specific manufacturer of that DME implant. And these kept on getting denied over and over and over again. So what they were able to do was use our predictive engine to find out there was a very specific clinical trial number and very specific documentation that needed to be submitted with those implants. So what they were able to do was build an edit in their host system, their billing system, to stop all of those before they went out the door and actually slap on that clinical trial number and the very specific documentation. And when that was done, all of those claims going forward were being paid on the first pass. They were actually able to recognize, not just with that scenario, but many other scenarios specifically related to biosimilars and orphan drug use, close to an $8 million annual savings. And the last case study I want to talk about was another one of our clients that used the Rev Integrity Suite to really have our suite interrogate different types of injections, knee injections, spinal cord stimulators, things of that ilk. And what they were able to find was they were originally getting denied, particularly when they were being billed out of their ASC locations, that they were denied because they needed very specific documentation specifying why they went with the treatment path they did, why they would continue injections as to other alternative treatment paths. The predictive engine was able to help them understand what documentation was needed to get those paid faster. So if you take anything away from this quick demonstration, we would love to talk to you, hear your pain points, and let you know that we do have a predictive engine as well as historical denial insights that will help you understand where your pain points are, as well as to get you paid faster. And I'll leave it again with, it's just not sufficient anymore to wait 90+ days to get paid. It's going to ruin the bottom lines, and it's causing some really big pain, especially for the providers. So that was really quick. Love to have you come back and see more, but know we're here to help you. What I want to do right now is just close out of the demonstration, and I'm going to pull back up my slide here. And what I want to do now is we've received a ton of questions from the audience. So I'm going to start off with those seed questions as we have time. We've got about 5 minutes left. And I'm going to point the first question to Ritesh. Ritesh, this is the question that came in. Can you talk about some key metrics to measure the success of a revenue integrity program?
Yeah, that's a good question. I think there are a lot of metrics, but one theme I would talk about is most of the traditional RCM metrics talks about days in AR and some of the things which are probably at the 30-foot level. One recommendation I would add, as Dana showed, is to really get more granular in terms of tracking metrics, in terms of your initial response times from the payer across these 3 rev code categories. That's one example. Do you have metrics which talks about your initial denials for specific denial categories and how you're trending over time, be it month over month or quarter? So the one key thing about the metrics is just go 3, 4, 5 levels below, because that's where your specifics and granularity sits. So that's one example, is really starting to measure your initial response time or lag days. The time from you submit the claim to the payer and when they're really responding to you in terms of what that first response is. And specifically for the type of claims we were talking about around these rev code area levels. So that's one concrete example. And I'm sure that there are a lot more, but just focus on the key slices and dimension impact areas.
Great. And Dave, I think we're gonna close out with this question too, because I think everybody here wants to hear what you have to say about it. And I know you mentioned it a little bit before, but what, from a payer's perspective, what do they wish, if they could wave a magic wand, what would they wish providers would do to help them accomplish their payment integrity goals? Dave, you might be on mute.
Sorry, did that twice on it.
That's okay.
I think that, you know, as I mentioned earlier, it's really important that that the payers, if they had a wish list, number one on that wish list would be to be able to get documentation as requested as quickly as possible, and accurately as possible, so they could do their work. And in turn, that expedites, you know, their ability to give you that payment. I will tell you that you know, some of the payers are working on programs. Some are actually doing this, where instead of holding up and denying the entire payment, they're making, you know, they know there's an overpayment on that claim and they can calculate what it is pretty accurately. And so they're making assumptive payments. And I think that's an area of opportunity for both sides to work together to come to some kind of an agreement where that can really expedite the payment if you're allowing the payer to do their work in an expedited fashion by providing them the information they need. And then making that assumptive payment, still reserving the right to be able to validate that and you know, request additional payment if there's an error. But the error rates on this stuff is very low. So I think there's an opportunity, you know, from the payer side, if they could do assumptive payments on some of this, I think it could benefit both.
Great. So there's many more questions coming in, folks. We are almost at time, so we want to let you go on time. So we will make sure that we get back to you with the answers you're looking for. And again, thank you, Dave. Thank you, Ritesh. That was a wealth of information. I know I learned a lot. Let's hope some of those synergies between payers and providers start happening soon, data sharing and trust. But folks, thank you for coming. We'll be sending you this deck. We appreciate your time, and we hope to hear from you soon. And everybody have a great day.
Thank you.
Thank you very much.
Thank you all.